Hello and welcome to the Clinical Care Options Infectious Disease Podcast. I'm your host, Zachary Schwartz. In today's episode, we discuss key principles on ART selection for treatment-experienced people with HIV and comorbidities. We talk about how to design ART regimens for people with multidrug-resistant HIV and considerations for their comorbidities and drug-drug interactions. To hear a larger discussion or to follow along with the slides, visit the link in the show notes. Now let's get started.
My name is Josep Llibre, and I'm Senior Consultant in the Infectious Disease Division of the University Hospital Germans Trias in Barcelona, Spain. Remember that this is part 3 of a four-part program, HIV Care for Treatment-Experienced People, optimizing antiretroviral treatment and improving outcomes. I invite you to view the other medical minutes and the accompanying slide sets for this program on the Clinical Care Options website. This program is supported by an educational grant from BIP Healthcare. And let's start with the antiretroviral treatment choice in treatment-experienced people with HIV and comorbidities. How can anyone get multidrug-resistant HIV when there are so many excellent, amazing antiretroviral treatment options available nowadays? It's not an easy process. It's a long sequence of failures. First of all, failure of sequential, partially suppressive, older antiretroviral treatment regimens. They started with mono or dual nucleoside reverse transcriptase inhibitors treatment, then first-generation NNRTIs, efavirenz and nevirapine, or unboosted first-generation PIs with a low resistance barrier. Sequential functional monotherapy with newly developed antiretroviral treatments, and regimens with low barriers of resistance, typically, as we said, first-generation NNRTIs plus 2 nukes or first-generation PIs plus 2 nukes. Typically, people who you see with multi-drug resistance started treatment in the old days, before 2006. This has to be combined with some background factors, typically a bad or an irregular treatment adherence. This is based on the complexity or bad tolerability of early regimens in the old days, and very important severe social problems, including psychiatric diseases or any addiction, typically drugs or alcohol. And it's very important that you treat these situations, because otherwise, in your new treatment, in your new salvage treatment, they are going to persist and you are going to face again another treatment failure. These are complex cases, typically. 2 typical scenarios. The one is long rockers, people who started treatment in the 90s or in 2000, who have very long-lasting HIV infection. And the second one is people who acquired HIV infection through mother-to-child transmission, and they have been facing many virological failures during the childhood and adolescence. And very importantly, do not forget transmitted drug resistance that can jeopardize all this situation. People with multi-drug resistance typically have many comorbidities. Actually, you can say that all people with HIV, all our cohorts and all the people you see in your offices, they are aging, they are having more comorbidities, but people with multi-drug resistance typically have more, they are older and they have more comorbidities. The ARTIST-1 study is a phase 2-3 clinical trial proving the efficacy of a combination of 2 drug regimen composed of bictegravir and lenacapavir, a capsid inhibitor. As you know, it proved to have high rates of virological suppression in people with complex regimens, typically because of multi-drug resistance. In this clinical trial, with 128 participants, the median age was 60 years. 60 years. Remember that in the overall HIV cohort, in developed countries, the median age is between 50 and 52 years. So people with multi-drug resistance are older. They have a long median duration of HIV infection and treatment, a median duration of HIV treatment of 27 years. And they had typically multi-drug resistance with resistance against NRTIs, 64%, NNRTIs, 52%, PIs, 36%, and as an entry criteria, they could not have integrase resistance. The reasons for this complex regimen were mainly based on history of resistance or multi-drug resistance. And you can see that the comorbidities were common. Dyslipidemia, 75%, so 3/4, diabetes 70%, hypertension 60%, and chronic kidney disease in 23%. The Netherlands HIV cohort have been studying the people with comorbidities. They analyzed people with more than 45 years, and they had a median duration of HIV infection of 6 years. Most of them were receiving antiretroviral treatment, and most of them were having biological suppression below 40 copies per ml. The number, as we said before, the number of comorbidities is significantly higher in people with HIV than in people without HIV. And you can see that they had been treated typically with thymidine analogs in the past. And not surprisingly, they had higher levels of C-reactive protein, didimer, interleukin 6, and soluble CD4 and CD163, and fatty acid binding protein. And these differences between people with and without HIV infection were statistically significant. They had higher rates of hypertriglyceridemia, and they had also higher rates of hypertension. Regarding inflammation and the immune activation associated with age-related conditions, typically HIV and antiretroviral treatment is the most important. So having an HIV infection and having a non-suppressed virological plasma with in association with the HIV infection, but also all the co-infections. So typically hepatitis B and C, chronic hepatitis, tuberculosis, sexually transmitted infections. It's also related with the gut-associated lymphoid tissue, so with the immune dysfunction or the lymphoid tissue dysfunction. And this relates, as you know very well, with the epithelial integrity of the gut and translocation of bacteria through the blood and the HIV persistence. Many lifestyle conditions are associated with persistent inflammation. Typically, the most important ones are smoking, alcohol consumption, and a bad diet and weight increase. Typically, people with HIV smoke more than the overall population. They have more alcohol consumption, and they have more frequently consumption of drugs or other abuse conditions. This is associated with many comorbidities, many diseases, and actually this is associated in both senses. So persistent inflammation increases the probability of suffering these comorbidities, and all these comorbidities in their turn increase persistent inflammation. So cardiovascular disease, all cancers, but typically also non-AIDS cancers, diabetes, neurocognitive dysfunction, osteoporosis, frailty associated with aging, chronic kidney or liver diseases, and chronic obstructive pulmonary disease, and many others. So all these conditions increase inflammation, and chronic inflammation increases the risk of all these conditions in both senses. What can we do to improve chronic persistent inflammation? It's not easy. We have been trying in the past many anti-inflammatory treatments, many immune suppressive treatments, broadly neutralizing antibodies. None of them have found a persistent association with an improvement in the inflammation. And if I had to say that the best, it's statins. And with the REPLIEVE clinical trial, it has been proven that in people with low to moderate cardiovascular risk, the administration of a statin, that was pitavastatin, reduced the rates of major atherosclerotic cardiovascular events. The reduction was modest, 36%, but it was statistically significant. It has changed all the treatment guidelines of people with HIV. So the authors, Steve Greenspoon, believe that these statins have an associated anti-inflammatory effect in addition to the lipid-lowering effect. So if I had to say which could be the best treatment we can give to people with HIV with persistent inflammation in addition to antiretroviral treatment, probably is a statin. Well, let's go to treating people with multidrug-resistant HIV and comorbidities. What do we pretend with the new regimen? Obviously, the goal of the new regimen is re-establishing biological suppression. This is the most important thing we can do in this situation. So re-establishing and maintaining biological suppression. Obviously, this is going to prevent HIV transmission, and this is going to be associated with the best normalization possible of the CD4 cell count and the CD4-CD8 ratio. And in people with comorbidities, which are frequent, as we said before, is the best tool we have to reduce inflammation. The guidelines, all the guidelines, but particularly the US Department of Health and Human Services guidelines, say that biological suppression with antiretroviral treatment is the only and most important recommended strategy to reduce persistent inflammation in this situation. Two main messages regarding the reduction of inflammation with antiretroviral treatment. The first one comes with the START clinical trial. In this trial, we proved that every person with HIV infection had to be treated with independence of the CD4 cell count or the HIV viral load. So all people will have a benefit with antiretroviral treatment. No longer we have to face a decision who to treat or not to treat. Every people with HIV infection has to be treated. And this was associated with an improvement, in this case, of levels of interleukin-6 and D-dimer over 5 years. And the second one, the earlier initiation of antiretroviral treatment is associated with the reduction of inflammation. And this is because the early initiation of treatment is associated with a smaller HIV reservoir. So the earlier you start antiretroviral treatment and you achieve biological suppression, the smaller the HIV reservoir. And this is associated with lower rates of low-level viremia, bleeps, biological failure, and also persistent inflammation. Very important. That's why all guidelines recommend to treat everyone, and the sooner the better. Regarding the general principles to design an antiretroviral treatment regimen for people with multidrug-resistant HIV, sometimes with limited treatment options. The recommendation is to construct a salvage regimen or a new regimen with 3 active drugs. If you can combine 3 active drugs, it's better that at least 2. The only situation where the guidelines accept only 2 drugs is if you can combine dolutegravir and darunavir, so the best integrase inhibitor and the best protease inhibitor. But if you have to build a regimen with different drugs, sometimes with intermediate or residual activity, if you can, you must include 3 active drugs or sum up the equivalent in activity with partially active drugs, which is not easy to estimate. So you have to get a precise estimation of the residual activity. And as it has been said in other modules, having an expert advice is important in this situation. Obviously, you have to choose the best optimized background regimen with a high barrier of resistance. This is going to be based on a boosted PI, an integrase inhibitor, nucleoside reverse transcriptase inhibitors with a high resistance barrier, which include tenofovir, and sometimes an NNRTI, which could be etravirine. These are the drugs with the highest resistance barrier, the drugs are more likely to retain activity in people with multidrug-resistant HIV, twice daily ritonavir-boosted darunavir, twice daily dolutegravir if you failed an integrase inhibitor in the past, tenofovir, usually tough to avoid bone and kidney toxicity associated with TDF, and sometimes non-nuke. The only situation where we are not going to use any of these drugs if you have full resistance. This means more than 60 points in the Stanford HIV database, or if you have a severe treatment limiting toxicity. Then you can choose one or more than one, but usually one new drug with a new mechanism of action and no cross-resistance. These drugs are only approved in people with multi-drug resistance and usually limited treatment options that cannot build or maintain a suppressive regimen. This includes fostemsavir, which is given orally twice a day, 600 milligrams, ibalizumab, which is a neutralizing antibody, which is given intravenous every 14 days, 800 milligrams. It can be given by a slow infusion or a quick shot, intravenous. And then you have lenacapavir that is going to be started orally, but which is administered subcutaneously with 2 injections, 2 subcutaneous injections at the same time with 927 milligrams every 6 months. And then we have the investigational drugs, including the nucleotide reverse transcriptase inhibitor and translocation inhibitor, which is islatravir, and the broadly neutralizing antibodies with limited data so far and no data specifically in salvage. And do not forget the CCR5 blockers, the CCR5 antagonists, Maraviroc. But if you have a low CD4 cell count in this situation, it's quite unlikely that you are going to maintain an R5 trophic virus. Where are you going to think in administering one of these drugs? It's quite easy if you do not have a complete activity of darunavir and dolutegravir. So if you do not have a complete activity of both or either darunavir and dolutegravir, you probably need a drug with a new mechanism of action in your salvage regimen. The tolerability of all these drugs is good. They do not have specific adverse events patterns. Obviously, adverse events are not typically analyzed in salvage studies because these people receive a complex optimized background regimens. So they receive not only evolizumab or lenacapavir, but they also receive a complex regimen with boosted PIs, an integrase inhibitor, nucleoside analogs. So it's not easy to identify the toxicity specifically associated with these drugs. But we can say that overall, the tolerability is good and it's not a limitation in the use of all these drugs. A key point, particularly in people with multidrug resistance and comorbidities and old age, is the association of the comorbidities and the problem of drug interactions. This is very specifically related to boosted PIs, because the booster, either ritonavir or cobicistat, may drive many drug interactions that they can be treatment limiting because these people usually receive drugs to treat hyperlipidemia, statins or other drugs, antiaggregants, antiarrhythmics, some antihypertensives. So you can face important drug interactions that can be treatment limiting. So in some people, you are going to try to substitute the boosted PI with a different drug to avoid these interactions. And this is very important, and you have to monitor this always in people with multidrug resistance. The booster is the perpetrator of the drug interactions, and a different situation is lenacapavir, which is metabolized by the CYP3A4. So every inducer or blockers of this CYP3A4 can have a significant interaction with lenacapavir, which is not common, but you have to have this in mind in people with lenacapavir. What happens with the inflammation in people with multidrug resistance when you start the salvage regimen? Well, you can see the evolution of the CD4 cell count. You see the persistent CD4 cell increase, which has not plateaued yet at the 4 years. So this is very important, a median increase of 300 cells. Remember that when you overcome the 200 CD4 cell threshold, that's we consider that like a life-saving threshold. So it's very important, this recovery of CD4 cells. You can see that this is associated with an improvement in CD4. This is the most important improvement we see. Also an improvement in insoluble CD163, and it's maintained flat, the D dimer. What happens with the immune activation? Immune activation, you can see the improvement in the CD4-CD8 ratio in relation with the biological suppression. The greatest improvement is seen in people who reach and maintain biological suppression below 40 copies, but also people who have declines in viral load below 400 copies or 1,000 copies also have important improvements in CD4-CD8 ratio. That's because even if you do not reach undetectability, if you have a significant improvement in your viral load, you're going to see an increase not only in CD4 cells, but also in the CD4-CD8 ratio. The only ones that do not show this are people who maintain more than 1,000 copies. So last but not least, remember that a multi-drug resistance in people with comorbidities and low CD4 cell counts is a life-threatening situation. So do not wait too long to start the salvage treatment because this condition is associated with mortality. This has been analyzed again in the BRIGHT study. Remember that the non-randomized cohort in the BRIGHT study were people with no active drugs remaining. So in people with no active drugs remaining in the non-randomized cohort, the mortality at 1 year was 14%. This is extremely high. And in the randomized cohort with 1 or 2 maximum active drugs, the mortality was 4%. but this was very well related with the CD4 recovery. So people who maintain a CD4 below 20 cells had a mortality of 15%. People who had an increase between 20 and 200 CD4 cells, the mortality was 6%, and people who had a recovery above 200 CD4 cells, the mortality was only 2%. And the mortality in this scenario of people with multidrug resistance and comorbidities and limited treatment options is high, and we do not delay the initiation of the salvage treatment. Well, this is all. These are my take-home messages. People with HIV and long treatment history and multidrug-resistant HIV are usually older, have many comorbidities that have an interaction with the biological failure and the antiretroviral treatment salvage. Recent studies have investigated the role of many ongoing treatments against the inflammation and the development of chronic morbidities in this scenario, and probably, as we said before, the control of the cardiovascular disease, the lifestyle conditions, and the administration of statin together with biological suppression with a new treatment is the best we can do to reduce this ongoing inflammation. When forming a new regimen for multidrug-resistant HIV after a biological failure, the new agents with novel mechanisms of action can be incorporated into the regimen. Not only can, but must be incorporated if you do not have a full activity of either dolutegravir or darunavir. Obviously, the primary goal of this new regimen is reestablishment of biological resuppression. And as we said, many studies have looked at the reduction of inflammation coupling together with the biological suppression. And finally, a message of caution in the interpretation of the evolution of these markers, soluble markers of inflammation in plasma, if they do not show a consistent profile in all the markers, and until further research provides more clarity in this scenario. So thank you very much for your attention.
Thank you, Dr. Llibre, and many thanks to you, our listeners, for joining. As a reminder, to view the full program on HIV care for treatment-experienced people, click on the link in the show notes. And to get access to all of our new podcasts, you can subscribe to the CCO Infectious Disease podcast on your favorite player. Thanks, and we'll see you on the next podcast soon.